Hello and welcome to Health Affairs This Week. I'm your host, Jeff Byers. We're recording on September 26, 2025. Today, we welcome Ejnes from Brown Health Medical Group, who wrote a forefront article titled Deprofessionalization, an Emerging Threat to the Physician Workforce. This is as good a place as any to promote our second Insider Trend Report that we released in July. The report is titled The Healthcare Workforce, a Challenge in Sustainability. Check it out. As it serves a nice foundation for what Yul and I will talk about. You'll also want to get on the ground floor as we are releasing our third Insider Report this year in October on private equity and its impact on healthcare. And now let's talk about deprofessionalization. Yul, welcome to the program.
Oh, thanks a lot, Jeff.
Yeah, so you're a practicing physician. Generally, can you frame the physician work experience for us?
Yeah, I mean, these days, a physician is very likely, much more than ever, to work in a large group of various ownership models, physician-owned, academic health centers, insurance companies, venture capital. And according to some of the surveys, up to 80% of physicians are employed, and that number isn't going to be going down. And it's a contrast to the small physician-owned practice that I started in decades ago, in that today's physicians are going to have less control over their day-to-day work outside the exam room, and then sometimes even in the exam room, because non-physicians are managing and making decisions on staffing, scheduling, contracting, compensation, in return for physicians being relieved of many of the headaches that the physician owner model had years ago. But, as I argue in the article, I think in the trade-off, there are some new headaches that physicians are having to deal with.
Yeah, so are these new headaches why you're retiring?
No, actually, it's for personal reasons. I'm hitting the age where I want to leave before my parts start to break. I think having experienced a lot of the change going from a two-person practice in 1990 to where I am now in an academic health system-owned practice, I think I've navigated the waters, and I think I've worked through a lot of solutions to the problems I identify that I hope others will listen to and adapt to their organization, since this is how it's going to be for physicians, and we got to make it work.
Yeah. You outlined some of those anecdotes in the forefront article, and we'll make sure to talk about those today. And I also encourage readers to check out the actual article, as I'm sure we won't get into everything. But it's nice to know that you know, on your way out, you can get some jabs in while also providing the perspective for us of the wisdom and how you've navigated your career. So, just looking at what is deprofessionalization and like how does it manifest itself as more physicians become employees? As you noted, that stat of 80%, like physicians are becoming employees. What's at risk there?
Finding a definition is actually a hard thing to do. It's a term I came up with probably about 10 years ago after an experience I had in my day job. And I didn't even know if it existed as a word, but it turns out to be in the literature. I think of it as the loss of physicians' identities as members of a profession with its unique roles and responsibilities, expertise, and special relationships with their patients. And I also view it through two lenses. I mean, intrinsically, how physicians feel about themselves as professionals, and then extrinsically is whether the employers view the physicians as professionals or just another group of employees. And I think it's a result of how managerial practices get applied to a medical practice. Managerial practices may work in an airline or maybe a factory, but conflict with the needs and values of physicians, professionals.
Yeah, and I want to unpack that statement of what you just, because when you talk about deprofessionalization and about a certain loss that can come with a profession with that idea, don't talk out of turn, but like I do kind of wonder, like how has AMA, they've been protecting physicians and as a professional class for a very, very long time. As many of our listeners, I'm probably have read The Social Transformation of American Medicine, which outlines that quite a bit. Any thoughts on that, or like how they're like with the increase of employers, how has AMA responded?
Okay, and I should give you a disclaimer. I'm actually a member of the AMA House of Delegates, so I'm involved with AMA through representing the American College of Physicians. So I'm familiar with what they're doing in this area, and actually, it's quite a bit. There's a whole collection of materials called AMA Steps Forward. And the focus has been really on physician burnout. And this is not burnout, but intersects with burnout quite a bit. So a lot of conversation about how to give physicians voice, if they work in large organizations, how organizations can help preserve the professional part of what physicians do and in terms of patient care and preserving the relationship. So actually, in terms of tools and just raising awareness, in fact, I think they have a program that recognizes healthcare systems that do the right thing in terms of making their physicians feel like physicians. So yeah, that actually is quite maybe not as well known a set of resources, but they've been talking about that for a few years.
Well, fantastic. Thanks for taking that side quest with me. When you talk about the managerial aspect of it, which you bring up in the piece, you write about the risk of deprofessionalization is more related to the practice size rather than who owns it, which I thought was a very interesting comment. Can you unpack that statement a little bit more?
Yeah, when a practice gets large enough, it actually takes on an identity of its own. It's the practice. So instead of being, Dr. Ejnes's office, it's now, so and so clinic or such medical. And also, as the practice gets larger, it needs to hire professionals to do some of the work that a larger organization needs done. Human resources, IT, contracting. And with each iteration, the separation between the physicians on the front line and the people managing the practice increases. And eventually, it ends up looking like some of the large organizations. It's an enterprise, more than it is a small practice, and that's independent of who owns the thing. I mean, I was involved in a practice that grew to 100+ clinicians, mostly physicians, owned by physicians. I owned 3% of it, but we had an organizational structure, management structure with office managers, directors, vice presidents, etc. Every bit as much as the large health system that we ended up joining a few years ago did, and many other healthcare organizations do. So, I mean, a lot of this can go on even if the doc nominally is the owner and the organization is accountable to the physician owners, or if it's owned by a not-for-profit venture capital, etc. I mean, certainly when ownership changes, the mission and culture may change. So if you're driven to profit as opposed to service, that's going to shade this. But even in its purest form, we're there for the patients. The organization becomes an entity unto itself, where its needs are often met at the expense of the needs of the professionals and the patients that they care for.
Yeah. So what's interesting, you mentioned on our prep before we actually started recording that you're retiring, so which is why I bring this up. When you look at this and you look at the stat that 80% of physicians are employed, and you don't think that's going to go down, and I can't tell the future, but I would expect that it won't go down as much either. So, like for a physician coming into practice or just out of residency, beginning to practice, like it might be change is scary for a lot of people, present company included. Like, what might you tell a young physician about to go through this, or like how you might recommend that they navigate the waters of like either owning their own practice or being employed, and changes of ownership, as specific, like a lifespan became something else recently.
Yeah, I mean, I think, and this is actually was one of the antidotes I listed in the article, is learning how organizations work and how to advocate for yourself and your patients within your own organization. I mean, I've been involved in professional societies for most of my career, the American College of Physicians primarily, and we spend a lot of time talking to young physicians, residents, students about how to advocate for your patients with a legislator, with a regulator, with insurance companies, but maybe not so much with the person who signs your paycheck, your employer. Understanding the ecosystem of a large organization. I referred to something called the Abilene paradox. And, basically everybody is ready to go and change something, and they go to a meeting and they walk out doing the opposite. And it's, the issue of personal loyalties, people not wanting to have a ding on their review for not being a team player, being shy, etc. And just understanding that ecosystem to not mitigate all the frustration, but at least understand why things happen the way they do, and then maybe learning how to have agency in that type of structure. Certainly, there's still some niches where small practice will continue and be an option. Direct primary care, for example, is one. Concierge medicine, which is another. But one can always leave a job if they don't like the conditions of their current job. But is the grass always greener on the other side? If most of us are employed and you're going from one employer to another, though there's an irony in that. You can leave if you want, which is the non-compete clause, which, getting back to my premise that physicians are treated as just another bunch of employees, except when they want to leave, in which case now they're a valuable asset that may not be able to practice across the street. But, those are the realities. And I know there's a lot of conversation now about getting rid of non-compete clauses in physician employment contracts. But there's ways of living in the system as it exists and will exist. I think there's just got to be a lot of learning, and I think that should start in the medical school and residency level, and the organizations mentoring young physicians to show them how to navigate, how to be able to be there for your patients and for your professional identity, even if you're in a large organization that's got metrics and policies and procedures and all those other things that we just love.
Yeah. The administrative state. Is there anything from like a personal level that you would recommend to them? My sense as a non-physician, and you can correct me if I'm wrong, is that physicians like to be in control. Like having to take directives from a manager or from an organization within an enterprise. Is there anything that you could touch on with that?
Yeah, I mean, the issue of autonomy comes up and the loss of autonomy. And I'll tell you, having gone from a 2-person practice to a 3 to a 17, et cetera, with each change, you lose some autonomy. I mean, if you're all by yourself, you can decide everything. When you have a partner, you have to compromise on things. So that's not specific to the employment model of practice. I think where physicians don't want to be told what to do is what happens in the exam room. And it's not just the employer. I mean, it's insurance company, prior authorization, all those wonderful things. In terms of things that, have to do with how a large organization operates as opposed to a privately owned company, then, yeah, you'll take direction. I mean, HR picks the insurance plan for employees. There may be rules for how you hire people. And physicians, I would think in general, accept that as something they're not going to be driving the car on because they're employees. I would say, though, a lot of these directives that are part of being an employee, physicians tend to be inquisitive by their nature. I mean, they have to be. They don't accept things at face value because sometimes, the diagnosis the patient came in with isn't correct. So I think, again, in contrast to how you might treat the cashier at the cafeteria or someone who's doing housekeeping, physicians, I think, like to know the why. And if it doesn't make sense to them, they want to have conversation about why it doesn't and see maybe things can change. I mean, I talk often with my colleagues about the tyranny of the 3 C's, which is compliance, coding, and computing, where things don't seem to work. And when the question is asked, why are we doing it this way? The answer is, well, compliance said we had to do it, or this is what the coders said. And these are all very valuable members of the team. I don't want to start getting hate mail from the CIOs and so on. But they give advice, and sometimes the advice is an interpretation that others may differ on, or it may be something that is in a perfect world, but in the real world where we're dealing with patients, we may need to do something different so that people want to have something more than because we said so when they're following direction. I mean, it's not realistic to assume that every physician is going to do everything the way they want in an organization of hundreds of clinicians and thousands of employees. But understanding how physicians work, where things matter from a clinical perspective, which may not seem on the surface if you're looking at things like scheduling and the call center. That seems like a managerial issue, but it's very much a clinical issue because it affects how the patient workflow works with the doctor, how much time the doctor has with the patient, and there needs to be a conversation and give and take in those areas. Even identifying which areas that seem managerial are in fact in that gray area between clinical and managerial.
Well, we teased out some of the antidotes already for deprofessionalization. For the listener, can you explain what those are? You don't have to repeat yourself if for the ones that we have talked about. But
One theme that came up as I thought about this is physician self-governance in areas where it's appropriate and it actually aligns with the needs of the organization. An example that I raised in the paper that got a little more coverage in a JAMA Viewpoint article several weeks ago is the organized medical staff, which was a model that was created, I think, at the beginning of the 1900s when physicians took care of patients in hospitals. And the organization was set up where the medical staff dealt with the clinical matters, the administration dealt with the heating, plumbing, cleaning, etc. And then where things were cross-cutting, they had the medical staff executive committee that worked things out. And in the current environment where doctors aren't going to hospitals, I don't go to a hospital anymore, but the issues of the divide between clinical and non-clinical is still there. Looking at a similar model. In fact, perhaps that's what unionization is trying to create. A model where the physicians have a vehicle to express their needs and communicate with management, but having it built in. The other antidote that I listed was putting physicians in decision-making places that are not just related to pure clinical. So, for example, I always like to harp on scheduling and the call center is, wouldn't it be nice if a physician had veto power over something that just made no sense at all, that might have made sense from, looking at what works at Amazon or, some call center, but not in the doctor's office. We have a lot of physicians in management, but they're managers with medical degrees as opposed to physicians with decision-making authority who can, speak to the experiences of the physicians and the needs they have in order to take better care of their patients.
in the questions I sent you, I felt there was a little bit of a paradox of wanting less administrative work, but also wanting to be informed and involved with decision making, which generally involves administration and information intake. Like, what is the thread there from your end?
Yeah, I mean, I don't think it's either or. I mean, let's think about this. If we do this right, the organization benefits greatly. Happier doctors take better care of patients, which is what the organization presumably wants. There's less turnover. Turnover is super expensive for an organization in terms of loss productivity, which is another P word I don't like, in addition to provider. But so it's a win-win, and the issue isn't necessarily giving physicians control over things that they shouldn't have control over because they're employees, but having the dialogue, understanding why certain things. I mean, again, back to the call center. I mean, to administration, abandonment rate, on hold time, call volume they're the kings. Those are the things that you reward your call center on. From my perspective, it's, did the patient get booked at the right time in the right place with the right person? And they're not, at cross purposes to one another. It's just a different type of language and dialogue, and maybe not so easy to measure. But I'm not saying physicians should be organizing call centers, picking the software, picking the insurance plan with HR, but the things that affect what goes on in the exam room, even if at first blush they don't seem to be relevant, and in fact are. I think docs should at least have a say in a vehicle so that they don't get everything that they want, but at least what they get is heard. I mean, one of the expressions of frustration that I hear sometimes, which breaks my heart, is from a doctor, who's gone through all the training and has some experience in practice, is, I'm just an employee. I mean, how sad is that? And I mean, it's got to be sad to the person saying it, and it sure hurts a colleague. I think we need to structure the organizations in ways that doesn't happen. You may not like what decisions are made, but at least you feel that you're still a doctor and not just an employee.
So, Dr. Ejnes, before we wrap up, again, listeners check out the Forefront article. Is there anything that we haven't gone over that you just like to make sure that we touch on today?
Yeah, back to the antidotes, another one that I think we really need to take a look at, and it's a conflict between the managerial way and our way, is this fixation on centralizing and standardizing everything, which is, it makes sense. If you're making quarter-inch bolts, or if you're, flying a fleet of 737s to standardize and centralize, but the one-size-fits-all doesn't work for everyone. It works for some things, but not. But the conversation often becomes, we need to do X, Y, and Z differently so we can standardize and centralize, when it should be the other way around, saying, we're going to try to standardize and centralize so we can do X, Y, and Z better. And again, this is an area where the physicians, the professionals can negotiate, have a conversation with the managers on certain things. It makes sense to standardize and centralize, supplies. Great example, even having medical assistant pools, whatever. But certain other things, such as Dr. X wants to see their new patients primarily in the morning or back to back, versus Dr. Y wants them spread out, where the systems can accommodate that if management wants to, but the mantra is, well, standardize templates, make it simple for everyone to do their work except for the physician and their patients. So that would be another plea to management in terms of trying to make the professional feel more professional, and not just like another widget that is part of a system that looks to make everything same.
Well, Dr. Yul Ejnes, that sounds like a great place to wrap up. Thanks again for joining us on Health Affairs this week. I'm sure conversations on the workforce will continue.
Thanks so much, Jeff. I enjoyed talking about this.
Yeah. And if you, the listener, enjoyed this episode, send it to the Rhode Island Red in your life, and we'll see you next week.